Hello, good morning. My name is Kristy Murray. It's a pleasure to be able to speak to you and discuss our study. Thank you to Dr. Nina for the introduction. Of course, I'm giving this talk on behalf of Dr. Sally Gatchalian, and believe me, I wish more than anything it was her giving this talk. But I'm happy to be here. I wish so much I could be there actually in person instead of here in Houston. But thank you for the invitation, and it's a real honor. So I'm going to be talking about our study on tuberculosis in Bohol. And we have three different papers that are published now. One, the master study that was published in Emerging Infectious Diseases, looking at prevalence of TB in children. And then we also did another study looking at geospatial and hotspot analysis of our cases, and then looking at this risk assessment tools. This is actually coming out this next month in the American Journal of Tropical Medicine and Hygiene. And just to give you a little background as to who I am, where I am, this is the city of Houston. This is downtown Houston. This is all the Texas Medical Center here. It's really a Texas city. We call it a medical city. Texas Children's Hospital is where I work. This is our main hospital here. Our pavilion for women here, where we have labor and delivery and OB-GYN services. Our outpatient clinic here. Our children's nutrition center here. And then this is Feigen Research Tower. This is where my office is and where my labs are and where I pretty much am every single day. So Houston is a great place. And again, it was just a really nice way to have a partnership between Texas Children's Hospital as well as the University of the Philippines, and then with our stakeholders in Bohol. And just a little bit of background for me, I've actually had a long history of working in the Philippines. My first study there was in 1998, so 22 years ago. And I started working in Bohol, mostly was focused on rabies virus. And then a few years ago, after the earthquake, we began looking at pediatric tuberculosis specifically. So I'm going to go ahead and reduce my screen here so that way we can focus on the slides. So Bohol is a fantastic place. I'm sure if you've been there, you know it's absolutely gorgeous. It's beautiful. I always tease that it's such a rough place to work. Gorgeous blue seas and of course, warm, friendly people. It just really is a lovely place to be able to work. 1.2 million residents, and you've got the one main province, but then you've also got a lot of tiny little islands that are around the main island here. The capital is Tagbilaran down here. With 97,000 residents. And of course, tourism and agricultural are big in Bohol. So in 2013, on October 15th, there was a massive earthquake that hit, and I'm sure you all remember this, 7.2 magnitude, 230 fatalities, more than 900 people injured, 73,000 structures damaged, including a lot of homes and schools and churches especially, and of course a big economic toll. And with, of course, natural disasters, we think about all the different impacts that occur, and especially looking at what happens in terms of the medical sector. Here is one of the hospitals that I visited right after the earthquake had happened. And you can see here just the whole back part of the hospital actually fell off. There was a bit of a drop off here on a cliff, and then just everything within the hospital just completely destroyed, and they were working out of tents. And so when we think about this, people are all sleeping outside with aftershocks. We worry about vector borne diseases like dengue. We think about stockouts and medication and health service access. And then of course, with that, then we think about TB prevention and control services. Usually you end up seeing interruption of the directly observed therapy, so DOTS, as well as, not being able to follow up, diagnose, treat, or otherwise control tuberculosis in this type of setting. And then you've got a lot of people who are out of their houses, who are having to seek shelter, sometimes in these mass shelter settings, where of course then you're going to potentially increase the risk for TB transmission. So the goal of our study was to look at the prevalence of latent tuberculosis infection and TB disease in children and see whether or not there was a difference in the burden between those who are displaced and non-displaced, but then also look at risk factors for infection and disease. and then to understand the epidemiology of childhood disease in this post-disaster recovery setting. And here are a couple of my students here, Laura and Caroline, being able to come. I always love being able to bring students out, just like how I was back in 1998. It's just always nice to bring people in and really show them the joy of the Philippines, the beauty of the Philippines, and of course, most especially the beauty of the people of the Philippines. So the way that we did this study, we actually used EPI cluster sampling methods, which is a WHO method to usually look at vaccination rates and coverage, but it works beautifully for this type of study as well. And it's a validated study design. It allows us to generate a representative sampling, and that most importantly is a random sampling, but it does so in a way that gives us a population proportionate to size. So it's able to take into account population density and really give us a good generalizable estimate of what's happening. And the nice thing, it's low resource, very easy to implement, a pretty straightforward study design, and you're able to rapidly generate data. So with this, what we did is we actually, the typical way that you do an EPI cluster sampling is you have 30 clusters that are chosen, 7 households per cluster to give you 210. But when we did our sample size calculation, we hypothesized that the TST positive prevalence was going to be about 0.56%. It was hard to find really good data on this, but this is what we were estimating. And then our hypothesis was that in this post-disaster setting in the high-risk areas that were heavily affected, that prevalence would go up to 1%. And so based on that, we estimated that we would need a sample size of 4,200 children to sample. So with that, then we could either do more clusters, which would allow us to have more randomness, but of course, less selection bias. Or we could choose more households and keep the same number of clusters. But the issue with that is that it really does introduce selection bias. It doesn't allow us to be as generalizable to the area. Although, the bonus is that it is quicker and more easy in terms of feasibility. But we chose the harder route and decided to go with the more clusters. So we had 200 clusters total, 100 clusters in the heavily affected areas and 100 clusters in the least affected areas, 7 households per cluster. That would give us an expected 4,200 children if we expected an average of 3 children per household. So looking at our sampling frame, we chose municipalities that were in the heavily affected area, and then we also chose municipalities in least affected areas, and pretty similar in terms of the populations between those two. So what we did is we actually first went out, we did an interview of the household, we did a clinical examination of the children within the household. Of course, that was all after they were consented. And then we looked at TB risk assessment, and we placed the tuberculin skin test. And with that, we came back then 48 to 72 hours later for the second visit to read the TST. If it was negative and they had no symptoms, then there was no further workup needed, unless, of course, they had a known exposure within 8 weeks to a smear positive adult. Then we did refer them for IPT. Otherwise, if they were TST positive or if they were TST negative and had TB compatible symptoms, then we did chest radiographs. We also collected sputum if they're over age 5 or gastric aspirates on those under age 5. And then we looked to see whether or not they had 3 of the following. Did they have a positive TST test? Did they have TB compatible signs and symptoms? Did they have a positive chest x-ray with cavitary lesions? Did we have a positive smear for sputum or a PCR? And then was there also a known TB exposure? If they did have 3 of the 5 criteria, then we did consider them to be an active TB case, and they were referred for treatment. If they did not, then we assessed them as being TBI, so tuberculosis infection, so latent TB, and we referred them for IPT if they were under 5. So looking at our results, we ended up sampling actually almost 5,500 children. So like I said, we had 4,200 was our target. There were clearly more than 3 children per household. It ended up being like 3.6, I think, children per household. So that gave us a much larger number, but we went ahead and still did the all 200 clusters. So our positive TST was 355, giving us a prevalence of 6.4%. Remember, we estimated prevalence to be only a half or 1% at most. So we're way higher than what we had ever anticipated the prevalence to be. Looking at the heavily affected areas, we had one particular municipality where the TST positive prevalence was more than 10, that's in Abanga. And then also in our least affected areas, Bienvenido and President Carlos P. Garcia, CPG, also had really high levels of prevalence for TST positivity. For those that were worked up who are TST positive, we did end up finding 18 children who met the criteria for being active TB cases. And so they were referred for treatment. Looking at demographic and social histories on our children, the one thing that we did find to be a risk was if they were over age or 6 years of age and older. So 62% being TST positive compared to 47% being negative. The other thing we found statistically significant was being in one of these island barangays, so one of the villages that are off of mainland Bohol. 13.5% positive, TST positive compared to 6.4%, so about double. And then also looking at prior TB, treatment for prior TB being higher, having 6 or more people living within the home before the earthquake was higher and statistically significant. And then also whether or not they had a contact with someone with TB. So if they had a known contact, then it was higher. So 38% of those children with a known contact, TST positive versus only 10%. And then looking at age specifically, because one of the points that was raised is whether or not having that high of TST positive prevalence could be related to cross-reaction with BCG vaccine, which we know is given at birth. And so looking at this, we only had around, I think it was 15 children total who were within that 0 to 1 year age group. And we did see a number of them positive for being TST positive. So those could have been related to cross-reaction with BCG. But that would have been an incredibly tiny number of kids, children, infants, compared to the others. And as you see here, even though our bigger bulk of children enrolled were in this more middle group between 1 and 7, you can see that the TST positive prevalence starts to really go up, especially after about age 8. It starts to steadily increase to about 18%, 19% by the time they are age 14, which is really concerning when we think about it. So while the overall prevalence was 6.4, when you get into these higher age groups, you've been around longer, and so they've had more of an opportunity to be exposed to TB, that positive prevalence really goes up. And then looking at, of course, the natural disaster and its impact on TST positivity, remember we hypothesized that the heavily affected area that we would expect to see prevalence higher, and we actually didn't. It was the opposite, which was a really surprising finding for us. Almost 55% were TST positive in the least affected areas versus 45%. And the one thing that ended up being statistically significant in this was that the child being displaced, but it was the opposite again, where it was almost 48% of children who were displaced were TST negative versus 40%. So of course, we would have expected it to be the opposite if we felt the displacement was related to an increased risk for exposure and for TB. It was almost statistically significant for those people who were living in shelters with 25 or more people, so 63 versus 54%. So that was higher in that group. So potentially living in more of the mass shelters could increase our risk for tuberculosis exposure. But it was interesting that we found the opposite of what we were expecting to find. So putting all these variables into our multivariate modeling, what we found was the history of contact with a known TB case, prior history of treatment for TB, being older, 16 to 14 years of age, as well as living on one of these remote island barangays, were all independently statistically associated with being TST positive. And looking at our map here, this was our heavily affected area. This is where the epicenter of the earthquake was. And then you can see where the different municipalities were, again, in Obanga being one of the higher percentages. And this is an area where there's a lot of rebel activity that's occurred. And so there's always been kind of a bit of fear and people being uncomfortable coming to this particular municipality. And then not only that, but the geographic terrain is actually really difficult. If it's raining, it's really hard to get through some of those roads. And so, just a lot of geographic barriers there, as well as over in this area too, in the least affected area. You've got a much further distance. As you can see, the provincial health office is all the way over here. So being able to get TB supplies, medications, diagnostics, everything out to this area, it just takes a lot longer. And this is, of course, CPG, where we saw really high percentage of children positive for TST, Bienvenido as well. So again, not what we were expected, but as we started to look at this, we're like, well, maybe there's an association with the distance from the provincial health office in terms of the increase in the positivity. And then this is just a breakdown by the different barangays that were sampled as part of the study. So looking specifically at these island communities in CPG again, this is far out there. You can see all these barangays that were assessed. We're seeing 10% and higher, even up to 29% positive TST prevalence, which is really concerning when you think about it. And then same with Inabanga, there was actually one island barangay that was 22%, Bienvenido. And so this is really concerning when we think about distance, we think about access to care, and just being able to get to these children to be able to assess them and to be able to prevent TB, as well as, of course, thinking about the adult contacts within the houses. We did see a significance in terms of difference. So the further out distance-wise you got from the provincial health office, this is looking at the rural health units, the higher the prevalence of tuberculosis or TST positivity. And then same with minutes, we also saw an increase, a relationship between the further away that you got, the greater the chance of TST prevalence. And with this, actually, what we found was that if you were an hour or more away, that was what was considered the most statistically significant. So the hour mark seemed to be the biggest break between in terms of prevalence. So the further away you are, the higher the risk. And again, that's more than likely related to just access to care, the supplies and stockouts that occur. So thank you. I want to acknowledge the people in our study who worked really hard. University of the Philippines, of course, Dr. Gatchalian, who is our PI for the project. And I need to change this right here because it is no longer Miss, it is now Dr. Nina. And congratulations, Nina, on your PhD. We're really, really proud of you. I know you worked so incredibly hard. And then also our team at Baylor College of Medicine, Lauren worked on the spatial analysis, as well as our TB doctors who are really just experts in that particular area. And then, of course, our stakeholders and partners in Bohol at the Provincial Health Office, as well as at Memorial Hospital. And then our incredible Bohol field team. I cannot even tell you how hardworking, how amazing this team was in being able to screen almost 5,500 children in just a couple of years. And be able to follow them and really collect good, clean data. And just they were a powerhouse, going to some areas that were incredibly difficult. So we have, of course, our nursing team, our data entry folks, data analysis individuals, as well as our physician team there who were really just fantastic at going out and really evaluating these children. And of course, a special thanks also to USAID and the National Academy of Sciences in the United States, who generously funded this study. And then in memory of Dr. Sally Gatchalian, I cannot begin to tell you how much Sally meant to me and just the impact that she had on me. I learned so much from her. She was just amazing, and I know we all miss her very much. So this is us here at San Lazaro Hospital, and then working together at the University of the Philippines at the completion of the study, in the Bohol airport, flying back. And then, of course, this was us in the very beginning when we first actually had all met together and put together this proposal. And we worked really hard, and we were really excited that it was funded. And then this is our study team out in Bohol. You will notice that we are pretty much an all-women team. So I have no idea how that happened, but we were somehow or another, we ended up just this female power team of women who are just so hardworking and just really smart, and just methodical in the way they worked. And just, I cannot even begin to tell you how proud I am of them, and just what a pleasure and absolute honor it was to work with all of them. And I love this picture here because, of course, Dr. Sally, if you know her, this is totally her. Just just the most amazing, nicest person you could ever meet. Just so much fun, and everyone, all of our team, just really looked up to her and really respected her. So it's an honor to be able to present this on her behalf, and I'm more than happy to take any questions. Thank you so much for listening. Thank you.